Objectives 7 and 8 for Chapter 7 are to discuss the coding and sequencing of pathological fractures and to describe the coding of osteomyelitis and explain the unique rule for coding coexisting diabetes and osteomyelitis. So this is going to deal with Chapter 13 in our tabular list, which is musculoskeletal system and connective tissue chapter. And in here we have issues with bones and joints, often called arthropathies, back disorders called dorsopathies, and rheumatism, which is a disease that is marked by the inflammation and joint pain, muscle pain, or even pain in the fibrous tissues such as tendons and ligaments. And most commonly, this deals with rheumatoid arthritis. Pathological fractures are in this chapter, Chapter 13, and these are fractures that are due to some kind of disease process and not a fracture from trauma. Trauma fractures will be in Chapter 19 of the tabular list, and we'll talk about those later on. They can be due to things like cancers. Remember our bone cancers back from our earlier chapter are often secondary cancers. So it is often metastasized from another location. It can be due to severe bone issues such as osteoporosis or osteoarthritis, which is commonly what we think about when we hear arthritis. They don't always say osteoarthritis. They will always say arthritis, but that is the most common type, and that's usually what they're talking about versus the rheumatoid arthritis we mentioned earlier. It can also be due to long-term medications such as steroids. Coding. The sequence for coding a fracture is to, and this again is specifically pathological fractures, is to code the reason that the patient is there today for the encounter primarily first, followed by any other secondary codes that are necessary. So if they're there today for the fracture, we're going to code that first, followed by the underlying cause of the pathological fracture. Excuse me. When coding for aftercare, which is, you may see some terminology such as a recurrent or a healed pathological fracture, we would use the 7th digit of these pathological fracture codes, and most of these are by location. But the 7th digit is going to be the initial encounter. So when we first see the patient for that, or anytime we're having ongoing treatment from that initial encounter. Then we have a 7th digit character of D, which is a subsequent encounter for fracture with routine healing. G is subsequent encounter for fracture with delayed healing. So this will be documented in your diagnosis. We have K, subsequent encounter for fracture with non-union. It's not growing back together. And then P, subsequent encounter for a fracture with malunion. It's going back together but incorrectly. And then S is going to be the sequela. So we would not find these codes as separate codes for sequela codes like we had talked about previously. If we have a sequela, we're going to code the initial pathological fracture code that we normally would in Chapter 13 as if they had a current issue. But instead of one of the initial or subsequent encounters, we're going to use that 7th digit of S to indicate the late effect or the sequela. Complications for pathological fractures due to artificial materials, so replaced joints or pins and things like that. If there are problems due to that, they're still going to be in chapter 19. So we'll look at that later on as well. Another issue we will see in chapter 13 deals with stress fractures. So these are often due to repetitive injuries, which can come from overuse of a joint or a bone. The particular types of activity, so very strenuous activities can lead to these. Impact type of activities. And these are very common to the bones of the feet, legs, both the lower leg and the upper leg, and the spine. Chapter 13 also deals with osteomyelitis. So, itis is inflammation, osteo is bone, and myelo is the bone marrow. So this is basically a bone infection, and they can be classified as acute, chronic, subacute. Acute is usually most commonly what we see in children. And this is the term they will use for a new bone infection. It usually comes on very rapidly. We see symptoms within usually 7 to 10 days. The good thing is it is more responsive to treatment and has a higher success rate of dealing with it as the acute infection. It is often termed, this type is often termed hematogenous, which means that blood originates or is carried by the blood. We also have a chronic osteomyelitis, and we see this more commonly in adults, but adults can still have the acute infection, depends on the situation. But chronic is usually persistent or recurring despite treatments. And we have another type called subacute. And this is a chronic low-grade bone infection. We usually don't have the systemic manifestations. It's very gradual in onset versus, say, the acute osteomyelitis. It can be going on for many months before it's diagnosed because of this lack of symptoms. And the most common symptom that patients will come in for, and that's usually found for, is pain. There is a subtype of our subacute osteomyelitis called Brodie's abscess, and this commonly occurs in younger males. And that's one of the eponyms. Osteomyelitis is commonly a secondary condition, which means that it's a result of something else. So some of our common underlying causes of these bone infections are diabetes, which is the most common reason, peripheral vascular disease. So again, this is disease problems, issues with the vessels, the blood vessels, other than the, so peripheral, other than the heart and brain. Sickle cell disease, AIDS or HIV, rheumatoid arthritis. Rheumatoid arthritis is not the old age wear and tear of the joints that we typically think about with arthritis, which is the osteoarthritis. This is an immune system problem, and often will occur very early on. Children, older teens, very young adults is where we typically see this, and it's damage to the joint based on an immune issue. Intravenous drug use, alcoholism, long-term use of steroids, hemodialysis, poor blood supply, or recent injury can allow this infection to invade the bone. So when we're coding for osteomyelitis, our codes are often dependent on the location, the bone, and the acuity, the acute, the subacute, the chronic, and so on. in our coding manual, it does tell us that we are to use an additional code to identify the infectious agent. This is up at the front of these codes in our tabular list. These codes are typically M86 codes, and so there are several pages of these. So if you are looking at one, you might not catch one several pages in to this category. You may not catch that initial direction in the coding manual. So this is very at the very top of that category, M86. So take a look at that. And it says to use the additional code to identify the infectious agents, which is typically a B code. Commonly with our acute osteomyelitis, we see Staphylococcus is the issue, and more commonly for the chronic type of bone infections, we're going to see E. coli. Okay, but of course there are other things that would apply as well. So these, if they're not diagnosed or if they're not documented, you can't, but if you have that documentation, you do add those codes. Also, at that same place, it tells us to use additional code to identify any major osseous defects, if applicable. So these are problems. Osseo is going to be the bone, the hard material, maybe some capsules, some joints, things like that. So if that's documented, you would also add a code for that. Now, when we're talking about diabetes, as we mentioned earlier, that is the most common cause of osteomyelitis. We cannot assume a relationship, and it must be documented by the provider. So just because a diabetic patient has osteomyelitis does not mean that it came from the diabetes. It must be documented. There is a combination code in our diabetes codes, E11.69, which states diabetes with osteomyelitis. That is in our tabular. When we look at that and verify it in our, it's in our index as diabetes with osteomyelitis. And when we verify it in the tabular, it says type 2 diabetes mellitus with other specified complications. So other than the issues listed above, so you can look at E11.5, .4, .3, .2, .1. These do not have osteomyelitis, so this is a complication, but it's other than what's listed above. So E11.69 is our correct code for that, as long as the relationship has been documented. And then we still, at that code in the index, in the tabular, it will also note to use additional code to identify the complication. Since we say a specified complications, we have to tell them what that is. And so that would be the osteomyelitis. And then, of course, with the osteomyelitis, if we have documentation of the infectious agent, we'll go ahead and add that as well as any osseous defects.